Hello, and welcome to today's webinar, Improving Data Sharing Across SNAP and Medicaid Agencies, Key Factors for Success During Unwinding and Beyond, hosted by the Center for Healthcare Strategies in partnership with Benefits Data Trust and funded by the Robert Wood Johnson Foundation. My name is Vicki Quintana. I'm a Senior Program Officer at the Center for Healthcare Strategies, or CHCS. Before we start, a few housekeeping items. All lines are muted as you join, but we will encourage you to put questions into the Q&A box throughout the event. Also, today's webinar is being recorded and will be posted to chcs.org afterwards. On the next slide is an overview of today's agenda. First, I will introduce our wonderful speakers. Then we'll start with an overview of the landscape of Medicaid policy to improve food access. Next, we'll explore bridging gaps in benefits access, how data coordination can bolster enrollment across programs, and streamline administrative efficiencies. And finally, a state perspective on streamlining and facilitating enrollment in South Carolina Medicaid and SNAP, followed by a question and answer period and closing. Next slide, please. So I mentioned you'll be able to submit questions during the webinar using the Q&A icon at the bottom of your screen. And we will watch those questions and raise them during the question and answer period. Next slide, please. Now I'll move into the introductions. The Center for Healthcare Strategies is a nonprofit implementation partner that works with stakeholders nationally to strengthen healthcare services to ensure better and more equitable outcomes, particularly for children and adults served by Medicaid. We work to advance more effective models for care delivery, more efficient policy and program design, and focus on more equitable care and opportunities to address the obstacles that stand in the way of health equity. And now I'm pleased to introduce today's speakers. Amanda Bank is a program associate at CHCS who supports policies that help state Medicaid agencies better address individuals' health-related social needs, particularly food insecurity, through expanding access to benefits and partnering with community-based organizations. Through supporting public sector partners, all her work centers a holistic approach to equitably address the whole person care needs of individuals served by Medicaid. Jillian Humphreys is a policy manager at BDT, working on a team that assists states in streamlining access to programs like Medicaid, WIC, and SNAP. Prior to joining BDT, she spent over 12 years working in local government in North Carolina. Her experience in this field took many forms, including caseworker, supervisor, subject matter expert, quality assurance manager, and program administrator. Lucas Caldwell McMillan is Associate Director of Policy at BDT. Lucas leads efforts to develop innovative strategies to create, refine, and advance policies and systems to improve benefits access. Before joining BDT, Lucas was a legal aid lawyer in Ohio and Missouri, where he worked in an innovative medical legal partnership to help provide legal services to children in healthcare settings. In his last position, Lucas served as the managing attorney of health and welfare programs at Legal Services of Eastern Missouri. Lori Risk is the Bureau Chief of Eligibility Policy for Medicaid Eligibility, Enrollment, and Member Services at the South Carolina Department of Health and Human Services, where she has worked for the last 10 years. Prior to coming to South Carolina DHHS, Lori practiced as an occupational therapist and served as an outpatient coordinator for senior living facilities in South Carolina, where she designed, developed, and maintained policies and procedures for outpatient and home health therapy services. Prior to this clinical experience, she spent 10 years with the Center for Excellence in Disabilities at West Virginia University, where she was responsible for writing and implementing grant proposals for disability and rural health programs. And last but not least, Chris Cranford is the Operations Manager for Medicaid Systems at the South Carolina DHHS. He began his public service career in 2014 as a help desk analyst at SCDHHS, supporting the implementation of, at the time, the new eligibility determination system. Since that time, Chris has held multiple roles of increasing responsibility, supporting South Carolina DHHS's eligibility and enrollment systems including business analyst, help desk manager, operations manager for the Medicaid eligibility determination system, and his current role overseeing multiple Medicaid eligibility and enrollment systems and functions. And now, without further ado, I will turn it over to Amanda Bank.
Thanks so much, Vicki. My name is Amanda Bank. I use she, her pronouns. I work here at the Center for Healthcare Strategies. And my hope is to provide you all with a quick snapshot of this moment in time as it relates to food security and Medicaid. Next slide. So the first big thing going on in Medicaid right now is Medicaid unwinding. As I'm sure you all know, at the beginning of the pandemic, states provided folks continuous enrollment in Medicaid. However, following the end of the federal public health emergency, states are no longer subject to this requirement. An estimate show that up to 15 million people could lose their Medicaid coverage. While some folks will simply no longer be eligible, millions are at risk for losing coverage due to administrative reasons, like forgetting to submit renewal requests on time. And people of color are most at risk. This is due to the fact that people of color are overrepresented in the Medicaid population, and they're more likely to experience volatility and instability in housing and employment due to historic and systemic racism. And so it's really a uniquely critical time to streamline SNAP and Medicaid renewal processes to ensure that people have access to nourishing food provided through these programs, which we all know is critical to improving health and overall well-being. Next slide. The reason why Medicaid is such an increasingly important program to help address food insecurity is because as of late, there's been a lot of federal guidance related to how Medicaid agencies can and should be key players in addressing individuals' health-related social needs, including food insecurity. So, taking a look at the timeline on this slide, back in January of 2021, CMS released a state health official letter describing how federal authorities and other opportunities under Medicaid and CHIP can be used to address social determinants of health. Then in September of 2022, the White House launched their National Strategy on Hunger, Nutrition, and Health, which specifically highlights integrating nutrition into healthcare as a key policy priority in the years ahead. Then, in December of 2022, CMS released a new state 1115 demonstration opportunity explicitly covering housing, nutrition, and case management as official benefits through Medicaid. And while the benefit of nutrition supports is clearly relevant here, I also want to call out that case management can explicitly cover outreach and education to other state and federal benefit programs, including SNAP. So really highlighting that synergy across programs and need to better coordinate them. Then in January of 2023, CMS released additional guidance on the use of in lieu of services in Medicaid managed care to meet the HRSNs of Medicaid enrollees more effectively. And as a quick level set, in lieu of services are immediate or long-term substitutes for more traditional state plan covered services, and they have to be cost effective, but not necessarily cost neutral. And so included in that January guidance as a gold star example of what in lieu of service that managed care plans can offer was medically tailored meals. And so some states like California have even pre-approved a list of in lieu of services that managed care plans can offer to really encourage service uptake. And then most recently, hot off the press, just a few weeks ago, CMS released a coverage of HRSN services in Medicaid and CHIP framework, outlining 15 distinct HRSN services and supports that are allowable under Medicaid and CHIP authorities. Next slide. So there's been a lot of momentum at the federal level. And in response to all this federal guidance, the way that this plays out at the systems level is through states being offered the following opportunities to address food insecurity. So first, states can explicitly cover HRSN services as benefits through any of the authorities listed here. So I briefly already mentioned the Section 1115 demonstration flexibilities as well as in lieu of services. But I'd also want to call out that states can leverage HCBS waivers, community health worker state plan amendments, and CHIP health services initiatives. And again, specifics related to what services can be offered under what authorities and to whom can be found in that recent November guidance from CMS. Second, states can invest in food security infrastructure. Infrastructure might include funding systems upgrades across health and social care providers to address data interoperability challenges. It might also look like expanding healthcare organization referral networks to relevant social care providers in communities. And there's a lot of other ways that states can make really important infrastructure investments and improvements. Third, states might also start to develop mandatory screening for social risk factors, and in conjunction, develop robust referral networks to relevant community-based organizations to help better meet individuals' social needs. And then finally, states can streamline state and federal benefit enrollment systems across SNAP and Medicaid, which is a lot of the work that we've been exploring in this project with BDT. And so I know that was a lot, but for those interested in taking a deeper dive into the opportunities for Medicaid to better address food insecurity, we just released a report yesterday exploring all of these opportunities more in depth. So that report will be dropped in the chat, and I encourage you to take a look. Next slide. So now, taking a slightly deeper dive into these emerging healthcare partnerships with community-based organizations, it's really critical to acknowledge that there's often power imbalances and organizational cultural differences between CBOs and healthcare organizations, and these affect contracting terms and organizational partnerships. And so to help form equitable partnerships, there are a few essential elements for success. And these include mutual understanding, trust between organizations, and viable operational and financial agreements for both partners. The graphic on the slide also notes 4 key considerations for how state Medicaid agencies can better support these players to achieve these successful partnerships. So first, states can create defined roles for CBOs and CBO networks, or community care hubs, as they're often called, in these transformation initiatives. They can also establish dedicated funding and develop CBO and healthcare organization contracting guidance. States can also help to ensure equitable access to HRSN services, as well as develop a system to assess the impact of these partnerships on health outcomes and health disparities. And for more information about the ways in which states can help bolster these partnerships, Vicki can drop another CHCS report in the chat, which is also linked on this slide. Next slide. And so finally, I just wanted to wrap up my section of this presentation by providing a brief overview of some of the ways that states can innovate to streamline state and federal benefit enrollment systems across SNAP and Medicaid. So first, states can leverage enrollment technology innovations. This might look like developing a joint assistance program application or application system. It also might look like a statewide integrated eligibility system. States can also develop process innovations, so perhaps leveraging the ex parte review process, which is the attempt to redetermine eligibility based on reliable information already available to an agency without requiring additional information from an individual. States can also develop workflow management systems for document management. And then finally, states can look toward outreach innovations. So perhaps leveraging external partners like BDT to support outreach, or incorporating community voice. So asking community members who are navigating these systems how the system can work better for them. And then finally, states can develop community resource guides to provide a one-stop shop for where individuals can look for how to enroll, re-enroll, or find more information about these systems. And it's really important here to remember that there's no magic bullet. What we learned through this work is that every state leverages a variety of these innovations to make data coordination efforts work best in each individual state context. And so with that, I'll hand things over to our partners at BDT to take a deeper dive into what we've learned, exactly how it relates to how states are coordinating SNAP and Medicaid, and what they need moving forward to do this work more effectively. Next slide.
Hi, good afternoon, everyone. I am Jillian Humphreys. I'm from Benefits Data Trust. If you could go to, yes, thank you, the next slide. So Benefits Data Trust is a national nonprofit founded in 2005 that harnesses the power of data, technology, and policy to provide efficient and dignified access to these programs, improving people's health and financial security. Together with the national network of government agencies and other partners, we streamline public benefit systems and directly connect eligible families and individuals to assistance. Next slide. The ways we do that are by proactively helping people enroll in benefits, equipping other sectors to connect people to assistance, helping governments streamline access to assistance, and increasing solutions to improve access to assistance. Next slide, please. Our impact through December of 2020, since inception, is that there have been over $10 billion in benefits secured for families in need since 2005. Over 1 million households have been screened for benefits to date. Over 3 million people have received streamlined access to benefits through policy changes since 2019. And an average of $4,100 in benefits have been delivered to households in 2022. Next slide, please. So what we've been doing is we know that SNAP and Medicaid data coordination improving data across SNAP and Medicaid can make enrollment easier and more efficient for applicants and program administrators, while also reducing the burden of navigating the eligibility processes for these benefits and significantly improving health outcomes for people. Next slide. So in 2022, BDT, with support from the Robert Wood Johnson Foundation and in collaboration with CHCS, who's we're here with today, we conducted a nationwide review of how SNAP and Medicaid programs within each state coordinate and share data. Pre-survey discovery interviews were conducted with state administrators, county administrators, and policy experts to help inform the survey questions. And it included 31 questions, providing a mix of qualitative and quantitative data. We had over 100 respondents from both SNAP and Medicaid agencies, and this covered 46 states, 24 counties, and the District of Columbia. Next slide, please. So from our survey, we were able to find 3 key survey findings. The first is that integration is not necessary for data sharing across programs. States without integrated SNAP and Medicaid systems share data at almost the same rate as those with integrated systems. What we talk about when we say full and partial integration here is in our survey, we asked people whether they were whether their caseworkers were integrated, whether their system was integrated, or whether both were integrated. So when we say full integration, that means both. When we say partial integration, it's one or the other. And then of course, no integration means they don't do that across their systems or their caseworkers. States reported varying degrees of integration of their Medicaid and SNAP systems. While states have reduced both applicant and recipient burden and agency administrative costs through integration of Medicaid and SNAP systems, the objectives can also be achieved through data coordination, regardless of the level of integration. So lack of integrated systems is not an insurmountable barrier to data sharing. Next slide, please. The second key finding was that states commonly share data and SNAP and Medicaid data with third parties. So more than 30 states indicated that they share data with MCOs, managed care organizations, with a handful of states requiring MCOs to also screen individuals for food insecurity and identify individuals eligible for SNAP enrollment. MCOs are also interested in data sharing with states for streamlining access to benefits because enrollment in benefits can also improve health outcomes. In addition, at least 21 states reported sharing data with nonprofit outreach organizations, making it the second most common third party with which states share data. When working with state agencies, nonprofits can provide additional assistance to agencies with the goal of streamlining access to benefits. Next slide, please. The third top key finding from the surveys is that Medicaid and SNAP data sharing occurs in states across the political spectrum, regardless of state size or region. So I want to note here that the 4 states that did not respond to the survey were Alaska, Mississippi, Oklahoma, and Texas. That's important to note here because if you see that they are not included in this map, it's not because they don't, it's just because we don't have answers for those particular states. Of the states that reported sharing data across Medicaid and SNAP, 57% had a Republican governor and 43% had a Democratic governor at the time of the survey. In addition, states in every region with populations varying from 720,000 to over 39 million report sharing data across Medicaid and SNAP, including that data sharing has broad appeal. The benefits of data sharing recognized by a diverse set of states and stakeholders include efficient, accurate, and less costly administration of benefits programs. Next slide. So in addition to the top 3 findings, we also identified 4 areas for improvement based on our survey findings. So the first is providing clear and more aligned federal guidance. In the survey, 85% of the state respondents indicated that they would benefit from more federal guidance on data sharing and coordination across SNAP and Medicaid. Based on the survey results, BDT recommended federal agencies provide clear guidance on data coordination in 3 top areas. 1, providing a clear understanding of what can be shared from one program to another. 2, aligning verification requirements and processing dates across SNAP and Medicaid. And 3, making income verification tools, such as the Federal Data Hub, available for all programs. Second area for improvement is building cross-agency alignment. Many people who apply for one benefit are also eligible for another. However, many of these programs are administered under different agencies and regulations on the state level. So to improve data coordination, states can create better cross-agency alignment. Agencies can come together in various ways to identify challenges and barriers and come together to align on a vision and methods for improvement. Examples of cross-agency coordination include coordination across programs regarding policy and system changes, training eligibility staff across programs, or integrating agencies and/or eligibility systems. And those are just examples of how cross-agency alignment can take place. 3, the third area for improvement is utilizing expedited enrollment options. State agencies have additional federal options to use available data from one program to determine eligibility for another. Some of these options require data sharing across programs or with external organizations. In the survey, 27 states said that they share data across Medicaid and SNAP to support expedited enrollment and recertification processes, with 9 states indicating they do so as part of their express lane eligibility or fast track state plan options. And 4, using data to work with third parties. The 4th area for improvement is, as we mentioned earlier, 21 states reported sharing data with nonprofit organizations to help streamline their residents' access to benefits. 2 ways in which working with third parties can streamline access to benefits are by using data to conduct outreach to participants of other programs and using data to support social drivers of health. Next slide, please. So that was an overview of our survey results. I do encourage you all to check out our project page, which we will drop a link to in the chat. You can download on the project page, you can download the full report, including case studies conducted by CHCS of Colorado, South Dakota, and North Carolina. And you can also use the interactive map that gives an in-depth look into the state survey responses. You can scan individual survey questions and choose one or more responses to identify how individual states responded. I will now pass it to my colleague, Lucas Caldwell-McMillan, to discuss what the Medicaid Unwinding data tells us about Medicaid and SNAP coordination.
Great, thanks, Jillian. I'm Lucas Caldwell-McMillan, really excited to be here. As Jillian mentioned, we've got this pretty robust set of survey data from 46 states and numerous counties. And so what we decided to do with help from our research manager, Gabrielle Philippe Crawford, is look at what exists now as far as CMS unwinding data. These are the monthly reports that states have been required to send to CMS and are publicly available that look at a variety of results and outcomes and measures for Medicaid unwinding. I want to see if there's a relationship to some of the survey findings and whether there are any trends between what's shown, what states report as how they share data, and what CMS is finding, in particular in 3 areas. We looked at the data on what % of renewals were renewed ex parte or renewed automatically. Those ex parte renewals typically mean no information needed from the participants, renewed behind the scenes, either automatically by systems or by a caseworker. Average call center wait times, the % of pending renewals. So just how many, as a sort of a proxy for perhaps, how well states are being able to stay on top of the renewals, how many renewals are pending at the end of the month. And then also looking at out of the renewals, what % are terminated as a share of the total beneficiaries, looking at sort of whether folks are staying on Medicaid. Now, one caveat to the data that we had is that August data was just released last week. So we really only looked at 3 months of CMS Medicaid unwinding data, May, June, and July of this year. And that's because many states didn't have anything to report in March and April. And so really the only months that were available when we did the analysis were May, June, and July. So it's a limited 3-month window into what's happening in the states. But still we're able to find some interesting things. We didn't look at all of the survey data. We really just looked at the answers sort of to these grouped up questions. What types of data are being shared between SNAP to Medicaid? What additional steps are needed? So after the data is shared from SNAP, are there steps that are still needed on the Medicaid side to renew or determine eligibility? What did the state identify as the reasons why or the purposes behind sharing the data? And something that Jillian touched on, but what's the level of integration? Are the Medicaid eligibility and SNAP eligibility systems integrated? Are their workers integrated, meaning they're working on both SNAP and Medicaid? And so I will say, we'll go to the next slide. I was really interested in ex parte rates. That's obviously been in the news a lot. But the only factor that we looked at that had any impact on ex parte rates was the answer to this survey question at the top. When a state reported that they needed to take additional steps after receiving SNAP data, and this is participant level data. After they received participant level data, they needed to take additional steps, and this was a kind of select all that apply. And for the states that selected that they needed to take additional steps to verify household composition, there was a significant difference on ex parte rates. And surprisingly, for states who reported the additional steps to verify household composition, they had higher ex parte rates, on average 39% ex parte rates versus 26% for those states who did not report that they needed to take additional steps to verify household composition. So, just a quick explainer, household composition here just means, who's counted for purposes of household income counting purposes. Is it, grandma, grandson? Is it mom, dad, 3 kids? Is it just mom and 1 kid? Determining who's in the Medicaid household. So this was surprising. You might think that if a state's reporting they need to take additional steps, that might mean that their ex parte rate is lower, that there's less that they're doing with the data. That's not what we found when looking at the survey information and CMS unwinding data. My theory right now, and I'm happy to entertain questions in the Q&A, is that perhaps states that are generally identifying needing to take additional steps to verified household composition are further along in the process of really grappling with how hard and complicated using SNAP data is to determine Medicaid eligibility. So that's my best theory right now, is that maybe it's a way that shows that they've thought through some of the things they need to determine. And so that's my best explanation why you're seeing those states have a higher ex parte rate versus those states who don't report needing to take those additional steps when SNAP data is shared. We'll go to the next slide. So the other question we looked at is, what are the uses? What purposes are they using to share? And this again was, it had an other, but had options. And one of the options that a state could say that for why they're sharing and coordinating Medicaid and SNAP is to automate Medicaid renewal or redetermination. And for those states who selected that, there was a significant difference on call wait times. So the average wait time for states that reported that they're using data for that purpose reported an average wait time of 7 minutes versus 15 minutes for states that don't report that. So to me, that's a pretty straightforward story, hopefully, which is that if you're using SNAP data to automate Medicaid renewal or redetermination, you're hopefully redetermining more people eligible more automatically, sending less requests for information, hopefully sending clear notices to individuals saying, you've been automatically redetermined based on SNAP data. And you may just be getting less volume, potentially, of questions and less volume of work for your, frontline staff, because this is happening using SNAP data automatically. That straightforward story has a little bit of a caveat when we look at the other option that some states could choose, which is they were sharing it to verify Medicaid eligibility. So we asked both specifically about automating renewals and then also asked about verifying Medicaid eligibility. For those states who said, yes, we're coordinating data between Medicaid and SNAP to verify Medicaid eligibility, those states actually showed a longer wait time. Again, about similar difference, 13 minutes on average for those states saying they used it versus 6 minutes. Now, I think some of this might be for those states who said automate Medicaid renewal or redetermination, they may not have checked verify Medicaid eligibility, although you could select both. So I think that might explain some of the discrepancy. And also knowing that those states who selected verifying Medicaid eligibility may not be using it at all for renewals. So it's not surprised that now we're in the Medicaid unwinding and doing a high volume of renewals that you're not seeing a bang for a buck if you're just using that for applications as well. But certainly, at least for call center wait times, we did see a significant difference for those reporting automated Medicaid renewal or redetermination. I will say the other big factor for wait time was level of integration. I didn't put a slide in. I think this is pretty straightforward. I think for those of you who have been tracking the data and for those of you who work with state or local agencies, it's probably not surprising that when CMS asks you to report on average wait time and you have like an integrated system and integrated workers and probably an integrated call center, that you may, and in fact, we did see much longer average wait times for those who reported that their workers handle eligibility for Medicaid and SNAP, and did report longer wait times if their Medicaid systems and SNAP systems were integrated. I think that's a proxy probably for a little bit of the messiness of data on call wait times. I know I've heard from states that it's pretty hard to tease out when you're looking at wait times to a line that handles SNAP and Medicaid about who's waiting for SNAP, who's waiting for Medicaid. But we did see that difference, that states reporting levels of integrations generally reported longer wait times as well. And then I'll go to the last slide now. I think this is another surprising piece. We did ask, what types of individual client data are shared across programs. And for states that selected that they share financial information, we saw no significant differences between wait times or pending renewals or ex parte rates or percent termination. There was really no significant differences between the states that reported sharing data and financial information across programs and those that didn't. I'll say this, which is I think maybe a theme for the slides and a great intro to our next speakers. This work is hard and complicated. So I think what that shows to me is that just sharing the financial information may not be enough, and that how you use it and the devil in the details and the work that states have to do then to really put that into place is really important. And really happy to turn it over to Chris and Lori from South Carolina's Department of Health and Human Services to talk a little bit about what they've done, the hard work they've done in South Carolina, and just how complicated some of this stuff can get.
Great. Thank you, Lucas. And good afternoon. Thank you all for having us here today. My name is Lori Risk. I'm with the South Carolina Department of Health and Human Services. We can go ahead to the first slide. My colleague, Chris Cranford, and I will talk a little bit about our Express Lane eligibility process and how we use SNAP and TANF data to provide eligibility for children. Next slide. So our agency is the South Carolina Department of Health and Human Services. We're responsible for administrating the state's Medicaid program. Our Department of Social Services administers the SNAP and TANF programs. They're separate agencies, separate workers, and we do not share a system. However, we do share data for several different programs. We share data for foster care, so we enroll children in Medicaid based on the participating in foster care or adoption, such as through 4E through DSS. Third-party liability data. We provide referrals for medical support. And then, of course, for express lane eligibility, we receive that SNAP and TANF data. Next slide. So we automatically enroll children receiving SNAP or TANF using monthly data files that we receive from the Department of Social Services, and Chris will speak more to the technical side of that. We do this for both initial enrollment of children as well as at renewal. So at renewal, those children are automatically renewed. Even if there are other members of the household that require a review form, those children are extended. We receive specific data elements from DSS, including their DSS case number, a first name, last name, address, date of birth, and social security number. They can opt out of ELE. That information is found on our notices and is also found on the DSS application. So when we initiated the program, DSS added language to their application, providing families the opportunity to opt out and letting them know that their information will be shared. So we implemented back in September of 2012 for both application and renewal that involved a state plan amendment. We developed the data sharing agreement with DSS at that time. We created ELE specific notices so that families would understand why their child was enrolled, what that means, how they can opt out, how they can have questions answered. And then, as I mentioned, it also involved updating language on the DSS SNAP and TANF application so that families had the opportunity to opt out if they chose. As of November 16th of this year, approximately 5% of our current members in the children's category are eligible strictly based on ELE. There are other children, of course, in households that their families had applied. They are receiving SNAP and TANF benefits, but their eligibility is based on that application. If they were to no longer become eligible for some reason with their household, when we would receive that reporting for ELE, then we would re-enroll them unless they had opted out of the program. Next slide. Now I'll pass it on to Chris.
All right. Hey, everybody. Chris Cranford, also with the South Carolina Department of Health and Human Services. I'll talk a little bit about how we achieve the ELE processes in our eligibility system. So every month, we get a data file from the Department of Social Services that includes any new SNAP or TANF approvals from the previous month. And this is for our auto enrollment process specifically, so the children don't have eligibility currently. We load that data into our system and execute a series of data validations on it. Some of those are that the member must be a year old or more, and the member must have a valid SSN. Both of those have a lot to do with preventing the creation of duplicates in our system, because if they're less than a year old, it's more likely they don't have an SSN in DSS's system, or they may not have an SSN in our system because of our deemed infant process. And so we want to try to avoid the possibility that we have a person enrolled twice with two different numbers and all of the confusion and issues that come with that. The member must, of course, also have a valid program participation code for SNAP or TANF on the DSS data file, and they must have a valid address on the file. When we load that file, the system will initiate a person search and match process to locate any existing records for the member. That, again, helps us to avoid the creation of duplicates and make sure that it is a new enrollment. And based on that search and match outcome, the system will either create a new case for the children in grant eligibility. We'll update an existing case where the children may not be currently eligible, or we'll skip the record if ultimately it falls to an exception and the system's not able to process it. Next slide. For our auto renewal process, we get a separate monthly data file from DSS that includes all SNAP and TANF recipients who had a benefit in the previous month. We again take that through a series of data validations that are very similar, but a little bit more relaxed than the auto enrollment process. We run our case review selection, where we identify all the cases that are up for review in a particular month. As a part of our series of annual case review processes, the system will attempt an auto renewal for any currently eligible children on a case selected based on that SNAP and TANF data. That'll include existing ELE eligible children where they were granted their initial benefit through the ELE process, as well as children who are enrolled through a normal Medicaid application or other means, but they're now up for the annual review process. If there is a sufficient match to the SNAP and TANF data, those children's eligibility will be renewed automatically, and we'll send a continuation of benefits notice to the household. We have individual disposition in our system for renewal and have for a long time. So in a lot of cases, what we'll see is if you've got applying parents and children, the children will be auto-renewed based on existence on the SNAP and TANF file, whereas the adults will still attempt an auto-renewal based on available income data and electronic data sources and things like that. But ultimately, if we have to, we'll send a review form for other members on the household while still allowing those children that are getting SNAP and TANF to automatically get that year's eligibility from the renewal process. Next slide. As far as how we achieve this in the system, so we customized our system to have what we call Medicaid ELE benefit evidence and an ELE product delivery case, which is basically where our business rules run. We have simplified eligibility rules on the ELE product that will grant eligibility in the children category based solely on the existence of the Medicaid ELE benefit. So it's not actually running any income checks on the data that's stored in the system or anything like that. It's just using the fact that they successfully processed through based on that ELE file. We do still have an age check in place so that we can facilitate the aging out of the children program when appropriate. And we have system validations in place that prevent the inappropriate creation or editing of the ELE benefit. Only an administrator role can create ELE benefit in an exception scenario. Only an administrator role can delete the benefit, and only an administrator can modify the start date of the ELE benefit. Next slide. There are a few considerations that we're looking at during the unwinding process. One of them is that our matching logic for both the auto enrollment process and the auto renewal process are very dependent on having an SSN for the child in our system already. So one of the things we're looking at is whether we could relax some of those rules and allow a match based on, say, name and date of birth or name, date of birth and county or something to let us both obtain an SSN for that child, which will improve our data quality, but also allow us to auto renew that child even though they don't have an SSN in our system. That leads kind of into that second bullet point where based on some of the flexibilities that CMS has granted us during the unwinding, we're also looking at how we can utilize those SNAP and TANF data files as a source for not only updated SSNs for actually the children and the adults, but as a source for updated contact addresses and other contact information so that when we do have to reach out, we can more successfully reach people and overcome that issue of kind of outdated contact information that I know everybody's kind of dealing with as a result of the unwinding process. Next slide. That's all we've got for today.
Well, thank you so much to Amanda, Jillian, Lucas, Lori, and Chris. That was a big task, fitting a lot of big and really detailed ideas into those presentation slots. So thank you for sharing your experiences and the learnings from this entire project and South Carolina with your learnings in the ELE and unwinding processes. We have received a few questions, and to remind everybody, you can put questions in the Q&A box. I see also you're getting a lot of applause, so just want to note that for our speakers. So one question I think is for Chris and Lori, and this is about the ELE data that you were just talking about. So could the ELE data be transferred to other programs with appropriate HIPAA business need documents, such as DHEC and school-based services where Medicaid services are rendered?
I can take that one. I think there's opportunity out there that we haven't fully taken advantage of. So I think we need to see what authorities allow us to do what as far as doing that with other programs. Maybe as a demonstration waiver or something like that, if it's not something already in place. But I think anytime there's the opportunity for kind of interagency work to provide benefits, we work with one of our community providers that does multi-benefit applications where they, with their incorporation of our application and DSS's application and other benefit programs, they're able to apply for multiple benefits for that individual. So I think there's a lot of untapped opportunities out there to do that. We haven't gone down that road yet, but definitely worth looking into.
Thank you, Lori. We've got one more that I think we'll start with Lori and Chris in South Carolina, and then I'll ask Lucas and Jillian as well if we know more about it from the survey. But the question is about consent for data sharing. Is there a part in the South Carolina process where participants would consent for sharing of their eligibility data at the time of application? Do you have an opt-out?
Yeah, so our data right now comes from DSS to us. So DSS has a question on their application that provides families with the opportunity to opt out of the ELE process. And then even if they haven't opted out, once we enroll them and we send them a notice indicating that they've been enrolled in Medicaid because of their SNAP or TANF eligibility, we provide them information on how they can opt out at that time as well.
Thank you, Lori. And I'll throw it over to Lucas and Jillian to see if we know any more about, on the broader scale, how many states have more of an opt-out process or require consents at time of application.
Yeah, we did not ask that in the survey. I don't think that was one of the 31 questions. I'm not sure. I think I've got them all memorized. So we don't have survey data on that. I will say, as far as trends, one is consent, I think, is an emerging issue around all of the data sharing. I think, for using SNAP data, I think typically the scenario that South Carolina outlined is what I've seen in other states, which is allowing for opt-out at the time. Obviously, on Medicaid applications themselves, there are some questions about consent to using other data too. And so I think that's a still developing field. And I'm sure there are states that do it other ways, but I would say what I've seen is pretty consistent with what South Carolina is doing, which is an opt-out.
Wonderful, thanks. We have another one for South Carolina, and this one offers some information as well from Arizona. So is South Carolina considering other ways of using SNAP data to address other health-related social needs? If so, what are you considering? At Arizona's Medicaid agency, they're developing processes to use SNAP, TANF, and WIC data to help members experiencing homelessness and are looking at other opportunities.
We have discussed looking further at how even for the fast track enrollment for adults, it's something that's been a challenge for us in the past when we try to align policies and so forth as been mentioned. I'm not as familiar with what is being done in the program area. I know there is collaboration, especially around children in foster care, or again, as I was mentioning, with children in an adoption situation under 4E or otherwise where DSS is involved. We also work closely with adult and child protective services with the agency, so our program area has initiatives that go on there. I don't know that any of those involve specific data sharing as much as just collaborative efforts to try and promote health for specific populations.
Understood. Thanks, Lori. This one is for Chris. Just to understand how the work gets done, who implements the matching logic and analyzes the effects? Is it agency staff or vendors?
So a little bit of both. So our eligibility system is developed and operated by a vendor. But we worked very closely with that vendor to kind of set their priorities, their business requirements, as well as participate in the operational monitoring of the system. So it's not a fully outsourced situation. For example, my staff in the operations area have responsibility for operational reporting and monitoring of jobs and reviewing of exception reports. So ultimately, to change the matching logic, we would identify the need, document it in an enhancement or change request to the system, and then work alongside the vendor to kind of design, have them develop, and then test and ultimately implement any changes.
Great, thanks, Chris. Okay, and I'll go back over to Lucas and Jillian. We got a couple additional questions about the survey. I believe you both answered the questions about what type of data sharing that we were referring to, but just to sort of tie a bow on that for anyone still wondering, there were a couple questions about what types of data sharing we were assessing. Is it all individual participant level data, and for eligibility purposes, were there any other types?
Yeah, so that's a good question. So the buckets that we had in our survey specifically were around enrollment, financial information, including income and assets, household makeup, such as how many people were in the household, demographic information, qualitative data, such as notes, stories, and then we had some instances where people could put in if there was additional information they were sharing. I don't have that handy, but those are the broad buckets that we were looking at when we were talking about sharing data. I don't know if Lucas wants to add anything to that, but.
Right, and that link we shared earlier for the reports would provide more information about the specific findings in the survey.
Correct, yes.
Okay, one more about the survey, and I know we spent a long time talking about this, but have we seen any differences in county administered versus state administered for these programs in what types of data is shared and how?
Yeah, that is also a good question. And no, I'm going back to one of our survey findings. We found that it really didn't matter what the makeup of the state was. States were sharing data at approximately the same rate, regardless. And that included whether or not it was county administered or state administered. So how they share data and what type of data they're sharing varies across the different states, but the fact that they're sharing is pretty consistent.
Yeah, I'll just add, this is when you do a survey like this, you always wish you could ask like 85 more questions. Just what Jillian was alluded to, of course, is that, we'd love to be able to say we don't like, how well and dig into some of the micro level of that, which we don't really have data on. So there might be variations on like use of data at the real micro level, like you're sharing financial information, but what are you doing next kind of things. But generally, we didn't see any differences in the broad trends of county versus state administered.
Okay, great. And I will add that the link we shared earlier does have a couple of case studies, and 2 of the states that we profiled do some county level work. So those might be some helpful places to start. Okay, then we had a couple of questions about outreach that states can do. So I think there are people wondering about, what are we referring to in terms of nonprofit partners and outreach partners, and what kinds of things did we learn in the survey about that type of data sharing purpose?
Lucas, you want to take that one?
Sorry, Vicki, could you repeat the question? I was looking at something else.
Yeah, the question was, what types of data is shared for the purposes of outreach? And if you could say a little bit more about kind of outreach partners states might be working with, that would be great too.
Yeah, we didn't ask, for purposes of enrollment and application assistance is typically what we see. And so what we're seeing in some states, and certainly North Carolina's case study is another good deep dive in some of the outreach plans, was sharing participant level data, and particularly to do data matching, which BDT has done a long time of matching who is maybe on Medicaid but not enrolled in SNAP as one example, and sharing that with SNAP outreach partners for the purposes of doing outreach and application assistance. So that's one broad trend that I think we've seen, but really, we didn't dig into the micro level of what they're using for it beyond outreach. But for that purpose, we were really talking about participant level data. So again, identifying likely eligibles, maybe through a data match, maybe through other ways, so that folks who are unenrolled but eligible could be at a minimum outreach to say you might be eligible, and maybe also provide some sort of application assistance or follow up to those individuals.
Wonderful, thanks. Okay, now here comes the tough one. Can you talk about the current state of federal guidance on data sharing? I feel like we get this question a lot. And this question asker says, we get pushback from our SNAP partners that they don't believe data sharing to MCOs for outreach purposes is allowed. So recognizing this could be different in different states, but I'm just asking BDT to share their wisdom on the data sharing federal guidance question.
Yeah, I can take that. I mean, I think our finding was they need more clear guidance. So I think if we said the overall landscape would be, at least from state perspective, is relatively unclear. And so certainly we continue to encourage our federal partners to do exactly what the recommendation says, which is really dig in and say what data is allowable to be shared and when. I would, BDT's worked a lot on data sharing agreements between state agencies. So I will say that, the field of data sharing agreements and what's allowable when you have a data sharing agreement versus what's just generally allowable can change. So, I think, I'd encourage agencies that don't have data sharing agreements that haven't gone through the process to do that. And we have a data sharing playbook on our website too that's worth looking at. And then just to raise some of the similar finding that we found with this survey, which is that, one of the real keys is to get separate agencies in the room and get them in the room early to talk about what are their concerns, what are the legitimate obstacles. Sometimes it's a technical consideration, and we've seen that, which is, how are we able to share this data? In what format can we share this data? And in what format can we ingest this data? And Chris sort of mentioned some of that stuff that they've worked through doing express lane eligibility. And sometimes it's legal concerns. I would say a lot of that digs into why you're sharing the data, and which data you're sharing from which agency. So if you're sharing from SNAP to Medicaid, there's a different legal analysis than Medicaid to SNAP, and certainly a different legal analysis from SNAP or Medicaid to MCOs. But I think there's a lot of good innovations happening with sharing data with MCOs. And I think some of the items that Amanda touched on around really CMS and others encouraging this sort of work and recognizing the importance of social drivers of health impact on Medicaid is a hopeful sign that there's going to be more guidance and sort of another sort of tool in the tool belt for those of you who are interested in starting new data sharing projects to tackle food insecurity and other issues.
Okay, and I'll remind everybody here that an evaluation link will pop up at the close of this webinar. And in the last minute here, I just want to take another minute to thank all of our panelists and presenters and acknowledge that we represent the people from our organizations who are here today, and there are many more behind the scenes making this all possible. And last, I'll just mention you can visit chcs.org or any of the links that we shared, BDT's website. Also, we shared several resources from BDT and CHCS on this and related topics. And thank you all for spending part of your day with us and for asking questions and engaging in the discussion. We really value the conversation. So thanks again, everybody. Have a great rest of your day and great rest of your week.